Tēnā koutou, tēnā koutou, tēnā koutou katoa. Thank you very much for joining us for our webinar today. My name is Annie Nicol. I'm a Business Development Manager at Uni Services and I lead the Ageing Research theme. I'm thrilled to be able to bring you a flavour of some of the excellent research we have coming out of the university in this space. Just a bit of housekeeping, please do put your questions on the Q&A function and upvote any of the questions that you would like to hear the answers to. If we have time at the end, we'll be getting the speakers to answer any questions that they'd like to answer. If we don't get to all the questions, we'll be sending out some answers at a later date along with the recording of the webinar. So without any further ado, to open our webinar, I'd like to introduce Dr. Andy Schenk, the CEO of Uni Services.
Thank you, Annie. Tihe Mariora, ina rangatira, ina kaikawe tūranga, tēnā tātou katoa. Ko te karakia o rangahoa kia whaihua tēnei. Hei karakia mai tātou katoa. Rangahoa kia whaihua, hei oranga mo te katoa. Meinga kia whai atu mata i te ihi, kia whakatu hononga whaitake. Kia hangai mata i te āmua. Ane ne whainga. Hei tua papa mo o mātou mahi katoa. Rangahoa kia whaihua, haumi e, hui e, taiki e. Kia ora tātou, ko Andy Schenk. Welcome everyone and thank you for joining us for this webinar. As I'm sure all of you know, in New Zealand and in many countries around the world, our populations are aging and both the challenges and opportunities around aging well are growing every day. With good luck, all of us will experience aging. And I think it is fair to say that all of us will hope to have a good experience in terms of our physical health, but also in our social and intellectual health as well. We have a group of speakers for you today whose interests and expertise span a very broad range of topics under the general umbrella of healthy aging. And I hope you will find that there are many ideas raised today that you would like to know more about. So please be in touch. To get things started, it's my pleasure to introduce Professor Ian Town as our first speaker. Professor Town is the Chief Science Advisor at the Ministry of Health. A physician by training, he has worked across both the health and education sectors and has published extensively in respiratory medicine. Much of his research has been translated into practice and implemented through evidence-based guidelines for the management of common conditions such as asthma, COPD, and pneumonia. His presentation today will focus on COVID-19 and its effects on older people and healthy aging, and the implications of the pandemic for research and for the public health system. He may also wish to provide some insights into the new government's plans for the health sector and the policy implications that arise from the health pledges made in the recent campaign. So we look forward to hearing you. Over to you, Professor Town.
Well, kia ora tātou, everyone, and thank you, Andy and colleagues, for the welcome and including the Ministry of Health in your webinar today. It's a pleasure to be able to talk pretty briefly about the COVID-19 pandemic, and I've been allocated 10 minutes with a warning at 7. So I'll have to mind my P's and Q's and keep to the topic. And you'll have heard from Andy that I'm not a specialist in the care of older people, but there are some issues that I'm able to highlight which will be of interest to you and remain of concern and research interest in terms of the impact of COVID-19 on various sectors of our population. So as Andy has said, I am a respiratory physician by background. I've been working at the Ministry as their Chief Science Advisor since last year, and the emergence and then impact of the COVID-19 pandemic on New Zealand has been, as has been said by so many, unprecedented, and certainly wasn't in my plans for 2019 or 2020. So that's a situation we've all had to face, haven't we, in terms of the team of 5 million. So I thought I'd just start with a brief recap of what we've learned and the impact of COVID-19 on the health and well-being of New Zealanders. So as of yesterday, there have been nearly 2,000 confirmed or probable cases here in New Zealand, which of course pales into comparison with the enormous impact that COVID-19 has had on a variety of other countries. There have only been 25 deaths, each sad in its own way, but that is a very small number compared to the devastating impact that has occurred in some countries without fully developed health systems. Now, interestingly, if we think about our older population, 340 of those 2,000 cases, around 17%, have occurred in people aged over the age of 60 years. And indeed, as you know, internationally, most of the deaths from COVID-19 have actually occurred in those over 70, with a steady increase in mortality rate as you move between 65 and 90. Nobody in New Zealand has died under the age of 50 years, and those that have died in those middle years have all suffered from underlying conditions. And it's well known that the outcomes of COVID-19 for those with underlying heart disease, kidney disease, and particularly lung disease are much higher, and the risk of death is higher. In New Zealand, we've had a very low number of people actually hospitalised, around 6% of that total, and only 17 patients have actually been admitted to intensive care unit. And this contrasts sharply with the experience overseas, where mortality rates in some countries have been much higher, and ICUs and intensive care facilities in our hospitals around the world have in some cases been overwhelmed to a devastating extent. In our world experience, which is now 6 or 7 months old, the elderly have borne a very heavy toll in terms of the impacts of COVID-19. And you'll all have read with concern, as we did, about the impact of COVID-19 when it enters particularly a residential care facility, be a rest home or a hospital facility for those with dementia and other chronic conditions. And we've seen here in New Zealand that of the 17 clusters that have been described, 5 of those occurred in aged residential care, and in some cases there were a significant number of deaths amongst those members of those communities. So there's a very sharp reminder from our international and local experience that those in residential and particularly hospital care are extremely vulnerable to viruses like COVID-19. And indeed, we know from other viral infections where, for example, influenza can cause high mortality amongst people who are very elderly or in poor health, or both. We have emphasised very strongly the importance of staff in aged residential care being very alert to the risk of the infection spreading within an institution, particularly seeing there's no effective treatment and as yet no vaccine. So we have been very mindful of training and practices within aged residential care to ensure that infection prevention and control precautions are taken and maintained to the highest possible standard. In our elimination strategy, which is the one that the government has pursued, we have had 4 key pillars of activity that you'll be aware of. The most closely observed is the number of people that are having tests. And we do include staff and residents of aged residential care as having a high index of suspicion. So we are prioritising those individuals, both staff and patients, for testing. And indeed, over 1 million tests have been performed in New Zealand thus far. And as you're aware, a number of people are now being tested repeatedly where they're at high risk in our border workers, and around 850,000 New Zealanders have undergone a test for COVID-19. We are just about to publish our new surveillance plan, which will include a similar approach to testing using the nasopharyngeal swab that you've all heard so much about. And we'll continue to have a very precautionary approach for those in and around the border and those in healthcare settings and aged residential care settings. So that's a summary of where we've come from and got to. New Zealand, I think, should be proud of its response. Again, the team of 5 million have worked together. But this is a government amongst a number of others internationally that have allowed science to lead the decision making. And that's made us here at the Ministry very proud of the role that science can play in setting government policy and leading the response. As Andy has said, we have some new ministers who are taking up portfolios within the broader health remit. So the Minister of Health, the Honourable Andrew Little, is well known to us and is a very effective minister, which we know from his other portfolios. So we're looking forward to working with him. He won't, Minister Hipkins, as the overall, the Honourable Andrew Little will be dealing with our other major challenge in the health sector at the moment, which is to implement or consider the implementation of the Health and Disability Review. And that major piece of work, which looks at all aspects of the New Zealand health system and its workforce, has been delayed significantly by the impacts of COVID-19. So we have a team of people working within the Department of Prime Minister and Cabinet who are going to be working with officials across the different agencies, but led by the Ministry of Health, to give effect to the Health and Disability Review. Those decisions about the future shape of our health system will be taken by ministers once the report has been prepared. We're also fortunate to have 2 associate ministers. One will be very well known to you, Dr. Asha Varal, who was a first-time Member of Parliament and has been made Associate Minister of Health, and she will take a particular interest, given her background as a specialist in infectious diseases. And then the Honourable Hene Panari will take an interest in Māori health and its implications for New Zealand and the future of the health system. So there is a short summary of COVID-19. Our expectations are high for the work of our new ministers, and we know that there will be an enormous emphasis on training and capacity building in public health. There's been widespread commentary, as you know, from senior international figures and also leaders such as Professor Sir David Skegg, who've observed previously that the public health system in New Zealand needs a boost. It needs more trainees, it needs more specialists, and the work of our public health specialists needs to be well coordinated on a national basis. So we see that as an important priority. The other priority that I'm currently involved with is the need for improved research and surveillance in regard to infectious diseases. It would be fair to say that this has not been a high priority for health research funding in New Zealand in recent times. So we're working hard with our colleagues at the Ministry of Business, Innovation and Employment to develop a set of research proposals that we hope will be favourably considered by the incoming government. That research will be important in the future to help us be better prepared for pandemics of infectious diseases such as COVID-19. And finally, just before I finish, you'll have heard news this morning about the initial success of one of the first vaccines, which is being distributed by Pfizer, the pharmaceutical company, and some very encouraging results from their trials showing that in countries with a high prevalence of COVID-19, their new vaccine appears to be effective. Whilst we don't have much data on that right now, it will emerge, the results of those studies will emerge in more formal reports in the coming weeks and will help our government select vaccines for use here in New Zealand. We do consider that the elderly, both the well elderly and those in care, will be a high priority for the deployment of vaccines in our immunisation program. So thank you very much for the opportunity of speaking with you today. I hope that set the scene in a small way for your discussions this afternoon. And thank you again for the opportunity to the team.
Thank you very much, Ian, for those insights into the current climate and for what we can expect after, as you said, such an unprecedented year. I don't think anyone foresaw this. Next up, we have Professor Ngaire Kerse from the School of Population Health. Ngaire is the inaugural Joyce Cook Chair in Ageing Well and is a well-recognised international expert in a number of interrelated areas, focusing on the care of older people. She'll be speaking about her National Science Challenge funded program about eating, sleeping, socialising and mobility. So take it away, Ngaire.
Thank you very much, Ani. Ko Mount Peel te maunga, ko Orari te awa, te Waiponamu, ko ko te rana, te whara te puna, ko Ngāti Pakiha te iwi, ko Ngaire Kerse toku ingoa. So, welcome and thank you very much for the opportunity to speak with you today. I'm going to share screen if I may, with a few slides. Hopefully start them off in the right order so that we can all be on the same page. So awesome, aging well through eating, sleeping, socialising and mobility. We'll talk about the National Science Challenge program that we've been funded to do as a collaboration, and mention a few other areas of research that are ongoing that I'm involved with. It's great to be able to talk about research, and I just think, you know, that the impact of research often is not felt at the time the research is done, but it is afterwards in the years to come. And I've got one example of that. So this is what we're all worried about and all interested in. This is the aging of our population with the number of millions and the number of years across here. Right now at 220, we've got about 83,000 people over aged 85. By 2060-ish, we'll have 383,000 people over age 85. So it doesn't take a numerical wizard to say that's a lot more people than we have now, and are we ready for that? More interestingly and potentially more importantly is the support ratio, which has been coined by the sociologists to think about the portion of the population who usually are the ones who are caring for and supporting that gorgeously older age group. And so when you look at the support ratio right now, we've got 15:1, which seems quite comfortable. That's, you know, anybody's 15, don't need 15 people to look after one older person or be their companion or promote them, drive them to things. By the time 2033 comes along, that'll be 8:1. And by 2063, that'll be 5:1. Now, of course, usually it's women who do that caring. So that's 2.4:1. So that support ratio suggests there's not going to be enough people around to look after our increasingly independent, but still with some needs, advanced age population. So this has been driving me for quite some time. Also, the idea that those population pyramids are very different. This is the non-Māori population pyramid. So these are the percentage of the population in the different age groups represented here. And you can see that here's the baby boomers, the bulge that is rapidly moving up that pyramid. So there will be lots of people in these age groups. This rate of change here is relatively manageable with, you know, I guess over the next 20 years of doubling. Whereas this rate of change here, while there's far fewer Māori in advanced age, the rate of change is much more rapid. And when we look at that diversity in our older population, here we have 520,000 Europeans, or that was 2011, that was. By 2026, that's growing to 780,000. So that's the vast majority of older people, and that rate of change is not quite a doubling. If you look at the Pacific, it's more than a doubling for both Pacific Māori and you know, almost a tripling for the Asian older people of New Zealand currently. So how will our aging demographic affect the way we live our lives, and how will specifically in those ethnic groups who potentially have different ideas, care and ways of caring, how will it affect their societies? We all want to do this thing called realise the longevity dividend. That just means that this is hypothetical and some people have been trying to prove this. Here we have personal and social capacity, engagement, functionality. You could also think of functional status and physical performance. And if we stay like this as we age, more older people getting older, we'll have a longer period in this time of disability. To realize this longevity dividend, we have to do everything we can to move this curve upwards. Now, the longevity dividend was started, the ideas of it started as an economic thing, that this group of older people would be a positive force in our society and that they would be spenders, they would be investors, they would be workers. It also relates to the amount of care people need. So ways to impact this dividend, we can say, okay, we've got to start way back here and do lots of things in early life. We've got some research about that, midlife. The biggest bang for your buck is to do something right now with this older population. So that's what's been driving me for aging research. So the gaps, which we don't know as much about as we would like. Oral health. I was mentioned in the election and there's some policies there from Labor I see. Oral health is really important. We had an oral health survey from 2010, which showed that more than 60% of older people receiving services that's in residential aged care or in support services in the community had significant issues with their teeth and needed more care. Those issues with their teeth directly relate to their overall health. Sleep health. Sleep health is equally important for younger people, but also for older people. Mobility, the cornerstone of what we think of in rehabilitation and in keeping people going. The unexplored and unexplained multi-morbidity, we have described it very well, but we don't know what to do about it. And we're constantly worried about equity with health in our disadvantaged and changing societies. So the awesome program aims to offer something for everybody across the spectrum from aged residential care through at-risk community into the Māori and Pacific populations. Our focus for Awesome is on innovation and evidence base, but mainly on sustained or sustainable implementation. So this is a schema. Our overall goal, of course, is optimizing function and well-being. We have specific groups of community dwelling, Pacific Māori and non-Māori, and we have ideas to continue to health promote and emphasize participation and functioning. Of particular interest are social connectors. We know that older people who are lonely do much worse. We know that there's lots of opportunities out there for people to do stuff. Age Concern is a partner in the research, and they have developed a social connector model, which is already working in a couple of places. We're going to implement one in Tauranga and in Auckland as part of the program. Activity, sleep health and oral health will be part of this functional improvement idea. We have an app called the Life Curve app, which I'll talk about in a minute. And so part of the program is based around that app. And we're focusing on multi-morbidity through large data endeavours with a PHO using all of their data to look at multi-morbidity in the primary healthcare aspect, and the inter-eye data through Hamish Jameson's group in Christchurch. Residential aged care, very important. So my passion, I love older people in nursing homes. I really enjoy working there. So we have a specific project implementing two really evidence-based things, actually giving them an oral hygienist for a year to work with them, and implementing CST, which is cognitive stimulation therapy. So this app that we've got is based on this hierarchy of abilities. This was first described in the Newcastle 85+ study. And you can see hiking, brisk walking, getting up from the floor, walking a mile. You can see it's getting worse and worse down here. Cook a hot meal, transfer from a chair, getting dressed, transferring from the bed. So the idea is that they develop this hierarchy or the order of losing these activities of daily living by watching people longitudinally. We would like everybody over time to be in this curve, the optimal curve, where they have longer periods of time in this area, this part of this curve, and less period of time in this part of the curve. We think for some people this is happening now. So what we want to do is engage with people who are in this area and offer them things to do and help them understand their own health and function. And we'll do this through an app. The app was designed and developed by ADL SmartCare and has been purchased by the Bay of Plenty DHB and is implemented and researched in the Awesome program. So again, that's sustainable. DHB is funded, is supported, has supported the project, and the funding from Aging Well supports the research, implementation and evaluation of the app. So this is a busy slide, but it just shows that there are several projects involved in the app. We tried to do something for everybody. I'll look at a couple of those sections of that overall map in a little more detail. So age concern with a social connector will be developed in Tauranga and in Howick. And the social connector will also be available for the Pacific Grandparents Study and for the Māori project, which is placed in Tauranga as well. The Sleep Centre with Rosie Gibson has thought about and has implemented sleep health aspects to use on the app, and also picked and is operationalizing sleep health measures in the measurements and evaluation that we're going to do. Professor Thompson and Dr. Moira Smith from University of Otago are implementing oral health measures and oral health aspects throughout the program. So for the at-risk group, that's those who are at risk living in the community, they will be offered and engaged with the Life Curve app. These will come from Bay of Plenty service users and participants in other research, such as the Super Trial, also funded by National Science Challenge. This group is at risk of decline, and we have good collaborations internationally to look at this group. They'll be engaged with, undertake baseline measures, use the app. Over 2 years, we'll see what's changed in their overall health. Indigenous and Māori networks, Ngāpuaronga is a Māori whānau wellbeing intervention, which has been proven to impact cardiovascular status in middle-aged Māori adults. We will now implement the program with Anna Rolliston at the Centre for Health in Tauranga and examine the impact of that program on the older members of whānau. So the older people are engaged with, the whole whānau undertakes the project with them, the program with them, and the evaluation is done around that. It is a world-leading program, I have to say. There is no other program that I know of that has actually changed BMI, changed cholesterol levels and overall cardiovascular health. We're very interested in how it impacts older people with frailty, older Māori who are maybe becoming socially isolated. The Pacific Island Family Study is a world leader out of AUT University. At the beginning of the Aging Well National Science Challenge, Pacific Grandparents Project was undertaken by Dr. Tan Totolo and others. And this will continue through the Awesome program to continue co-designing health improvement with Pacific people. The multi-morbidity network, so we have a TULIP consortium, which contains the LILACs data, which some of you will know about. We have two ways of examining this multi-morbidity. So multi-morbidity through primary health care. So this is the COMPASS, two-order COMPASS from the Wellington region, led by Lynn McBain, will engage and look at their data. We're identifying diagnoses right now, and then we will look at some patterns of comorbidities. And then in the way that New Zealand is so unique for, match that data to outcomes and see what the patterns of mobility that are worse that predict outcomes. And this will be a new way of thinking about multimorbidity, how to treat either aggressively or conservatively groups or profiles of conditions. We will do a similar process with the Inter-Eye network with Hamish Jameson and Christchurch. We will look at the pattern of conditions throughout support services and ARC dwellers and see how that plays out. Just coming to the last slide, don't worry, I know I'm prone to going over time. We have Judith Davey, who will help us with policy engagement and policy implementation throughout. The home care project is focusing on oral health, sleep health and cognition, and it is engaged with a provider in the Wellington region and we'll be very on the ground, from the ground up, working out how to improve oral health. So just one slide about other research that complements and goes alongside the AWESOME program. The AWESOME program started last year, has been delayed slightly through lockdown, but is scheduled for the next 3 to 4 years, total duration of 4.5 years. So I'm passionate about equity. Lilacs New Zealand is a longitudinal study of advanced ageing. Messages from Lilacs are being used now in TAS through their dementia network in the Midlands region, through ongoing Ministry of Health liaison. Excited to have Marama, Muru-Lanning, Joe Hukaka and Anna Rolleston as partners in other projects which are developing about equity, particularly equity around COVID. Second bullet, staying upright in residential care. My favourite, falls prevention. So this is a trial which actually managed to complete recruitment through this time period. Arnie, I can see you. Impact of COVID in residential care is a project under assessment. Robots for Ageing with Bruce McDonald in engineering, and music and movement, which is the Ronnie Gardner method, which is a quite hilarious activity to music program, which we're passionate about starting up here in New Zealand. So thank you very much, Arnie, for organising the webinar, and I'll hand you back and stop sharing my slides if I can work out how to do that.
Thank you, Ngaire. That was great. Always a reminder that we're all getting older. But our next speakers are providing something a little bit different. We've asked Associate Professor Marama Muru-Lanning to speak about the innovative research in the James Henare Māori Research Centre. Marama is a social scientist whose experience focusing on the environment gives her a bit of a different background to most of the people researching in the ageing and health space. In order for Marama to be joined by Professor Ngāpare Hopa and Dr. Ngahuia Dixon, we've actually pre-recorded her, her talk so that her whole team could be involved as well. So I'll just do some screen sharing and hopefully it'll work. Okay. Sorry, the sound's not working. Let me just start that again. Hold the line, caller, technical difficulties. Start it from the beginning.
Ngaire tēnei whare I te mata Hei te tiro ki ngā huatanga me ngā tikanga o ko tātou o Māori Nō reira tēnā koe, tēnā tātou katoa
Kia ora, nau mai, haere mai ki te whare rangahau o Hemi Henare. My name is Marama and I'd like to introduce to you two our two whaia who are special guests today in the James Henare Research Centre. This is Professor Ngāpare Hopa and this is Dr. Ngahuia Dixon. Both of these whaia have long careers in academia and we are very delighted that they have been working with us at the James Henare Research Centre, helping us to co-design research projects around ageing. So the James Henare Research Centre, and I'm very lucky that some of my colleagues are behind me, they've got our backs, so to speak. The James Henare Research Centre began researching with Kaumātua 4 years ago. And it was a road to home. I mean, to get recognised by the Health Research Council and the National Science Challenge Ageing Well, has taken a while, and we've had to create publications and we've had to show that we've been doing good work. But we're finally there. We now have 4 funded projects, and the one that we have been working on with these 2 whāia was called Hongi Hareru Hau in the time of COVID-19, and it was a rapid response project. And right from the get-go, from when we were funded, we realised that we had to work remotely with kaumātua, which is not the usual thing. Usually when you're working with Māori communities, you have to front up, and we do a methodology called kānohi ki te kānohi, so that's face-to-face interviewing. But for this project, we actually had to learn how to work with kaumātua remotely. And if you look over to my shoulder, there's Charmaine over here, who became the queen of online interviewing. And we were all in lockdown, and we were able to interview 23 kaumātua, 11 in the Waikato and 12 in Ngātiwai up north. And from those 23 kaumātua, we were able to do 63 interviews, which we analysed, and we have done thematic analysis on all of the data, and we actually have a publication out with the Royal Society. Now, working with kaumātua is not an easy feat. A lot of the time, you're juggling their mobility issues, also the fact that sometimes they're not always well, so you have to fit around their timetables, and also sometimes they have really busy lives, so you have to fit in with their busy social lives. But our commitment to working with kaumātua has enriched us all as researchers, and I'm very proud of the team at the James Ngaire Research Centre who have run around, been tono to kaumātua in the far north, as well as in Ngātiwai. We have 2 new sites opening up in the Waikato and also hopefully in Tauranga. So what we're trying to do is create a reach to work with kaumātua all over Aotearoa, all over New Zealand, because what we need to tell you is that kaumātua are all different. They all have different aspirations. They have different things that they want to achieve in their lives. Their environments are different. They don't all think the same. They are not a homogenous group. Kaumātua are as heterogeneous as any other group in New Zealand. And so we've been working with a model called the Punga Were Were model, which is the spider's web model, which was gifted to us by Whaia Ngā Parehopa. And that model is a model about building strong homes and strong relationships for kaumātua. And inside that web, we have things like, access to kai, access to food, which a spider, of course, needs. We have access to water resources. We have access to healthcare, access to pharmacies, opportunities for kaumātua to have relationships with their mokopuna, which is their grandchildren and their children, but relationships that are not extractive of their time. But I think I'll just pass that over to Whaia Ngā Parehopa now, because she's been thinking about this a lot longer than me, and she can articulate it in a way that is much more poetic than I could. Kia ora, Whaia.
Thank you, Marama. The model for thinking about issues, not this issue alone, is the spider's web. And I remember my mother always being fussy about, as children, about spiders in the house were not to kill them. And now I think I understand better how we could only use the cobweb with care in order to clean up this web. But I have found it, in whatever the issue, the web is a spider's web is a very good model to think with. And it's become very powerful within and among our own people now. It's easy to talk about the spider's web with kaumātua, who might be at various different points on the web. But to talk about the issues surrounding health, young children, taking care of ourselves as we age, the spider's web I've found, and my colleagues support me, that this is a good way to get to and help with finding ways to solve the issues that beset us in our community of elderly at the moment. Kia ora.
So I think the great thing about this Punga Wiri Wiri web is that it works in Te Reo Pākehā in English, with our Pākehā New Zealanders, but it also works just as well as a metaphor in Māori. So the web for us has been something that, as you can see here, we've created a visual. We've tried to make it a sort of bicultural model for ageing. We've seen lots of other Māori models, and we feel that this one fits really well for kaumātua and queer. Now, when we're using the word kaumātua here, we're meaning both older males and older females. And each tribal area has their own specific way in which they label older people. It could be Ruruhi, Karaua in the Waikato area where I'm from. Up north, they use kaumātua queer. In Tauranga, there are words like pakakea, and I think Whaia Ngaire, she's an expert and she could probably tell you them all. But what I want to say about the spider's web is that this is the beginning of a model for us at James Henare. After working for 4 years in this space, we've been thinking about how to best represent issues for kaumātua, and particularly going forward, how can people understand specifically the special issues that Māori kaumātua have, and how can we best support them in their ageing process? Because I'm going to be a kaumātua probably in about 20 years' time, maybe soon. But I think the fact that the University of Auckland is finally coming together and really pushing to do work in the kaumātua space is really important. However, with that push to do the work comes a lot of responsibility for the university to make sure that they treat kaumātua well, who may well be participants in the research that myself and my other colleagues at this university do. So there's a real commitment from the James Henare Research Centre to do good research with kaumātua, where they are honoured, where they are treated well, and sometimes where their mātauranga, or very special knowledge, where it is regarded as valued, and we don't just give $40 petrol vouchers, or we don't just give them these nominal amounts that we have been giving in the past. So we have to recognise that these people are really important and valuable. And so the James Henare Research Centre is really committed to making sure that kaumātua, who have limited time, remember, so their time is really important, that we make sure that we do the best with their time and that we create opportunities for them. I'm going to turn over to Whaia Ngaire.
Kia ora tātou. Yes, I think, bringing the model into operation, I think is important, as Marama mentioned, for both worlds really, because it will work. If we have a look at the model, when it's seen, you'll see all the relationships linking. And for kaumātua, as kaumātua, we have leadership roles, and those leadership roles are really important because they actually activate our younger people, our families, to move on and to get things done as we see. But besides that, we have whānau links. I mean, if we want to look at whakapapa, through whakapapa, we then again activate those links, and in that particular model, you have the whakapapa working. Now, if we look at the whakapapa world of Māori, that is what deems you a Māori or not a Māori, or you being part of a tribe or of being part of another tribe. And as Hirini Mokomead said, if you don't have the whakapapa, you don't belong. So the kaumātua model, the Punga Wiri Wiri model provides that link, irrespective of your hapu within that particular area or your tribe or whatever. It would work for any group, and as kaumātua, it is our or their or other kaumātua to lead those processes that allow that model to work. Looking at our tikanga, you have the tikanga involved in the model, and if we look at, take a closer look at tikanga, we have the tapu aspect, we have the noa aspect, we have, in other words, the sacredness or the sanctity of life. And so The model provides really the world in which the Māori, our Māori people operate. Again, in looking at the kaumātua roles in terms of health, as Ngāpare mentioned, it's looking at where families are able to support us as elders, as kaumātua. And therefore, we are there. That model prompts our people to come together. If we are to practice whanaungatanga, we need to use it practically. And one way of doing that is through supporting kaumātua, supporting others as well. But of course, being in an aged generation, we need it as we age, and we need to rely on our young people or our families to help us navigate those situations. In looking at other things involving the kaumātua role, it's getting our marae in order. And of course, this came up quite dominantly and prominently at a COVID level, where we as kaumātua had to look at how we were going to operate tikanga involving those people who had passed on. I think it was a great motivator for us to look at our younger people and to say that they needed to step up. That's all I've got to say at this moment, and I think it's a great model. I'd like to thank James Hinare Centre for being a part of it, and I'd like to pass it back to Marama.
Well, that was great, Fire. So because we're talking about young people at the uni, I think I might just turn around and ask any of the James Hinare, well, hey, what have you learned from this research working with kaumātua? What's the one thing that you've enjoyed, or what you want to share?
The importance and intergenerational memories to inform kaumātua's approach to health.
Oh, that's Nick. Charmaine.
Actually, their willingness to keep learning. So taking on all the new technology is through COVID, when we had to link in through all the different technologies, and how quickly they took to Messenger. So that whaka whanaungatanga has stayed in action.
Oh.
I kind of got two. So one follows on from that. Whānga, Where and I are friends on Twitter. We follow each other. So it's quite cool to know that there's kaumātua on Twitter. I've worked as a journalist, and so the method that we've used here is quite different to the usual way that people approach journalism, and so I don't know, it's just kind of made me consider different ways of doing that kind of practice.
Theory.
I think I was really startled by how much work kaumātua are doing, political roles, traditional roles, caring for whānau, and there's at least as much support going out from kaumātua to their communities, probably more in fact than there is coming in.
So what I've learned is that, and it's been humbling to be part of this project with Nan and Ngaire and all the team, but the value that is being put into our kaumātuas with all the researchers, and it's highlighted that our kaumātua are going to be looked after at this level.
Oh, thank you. Oh, well, me too, whānau. Mā waira e taurima te marae iwa honei I mā te tika mā te pono me te aroha e.
Wonderful insights into ways of supporting our kaumātua, and even on a lighter note, different ways of viewing punga werewere. Our next speaker again takes a bit of a different turn. We have Dr. Jenny Kruger, a midwife cum bioengineer leading the pelvic floor research group. If you've heard her name before, it's probably in the context of the wonderfully successful FemFit device and the growing uni services spin out JunoFem. Jenny, take it away.
Thanks, Annie, and thank you for the introduction. I am going to start just to share my screen. So hopefully you can all see that, and hopefully you can hear me. So yes, as Annie said, my name's Jennifer Kruger. My background is nursing and midwifery, but I've been in the Auckland Bioengineering Institute now for the past 10 years, where I lead a research group called the Pelvic Floor Muscle Research Group. And it's been wonderful listening to all the speakers so far about all the issues we need to take into consideration for the aging population. Sadly, the one thing that I have not heard mentioned once is incontinence. So that's kind of what I'm about in many respects. So if we go back a little bit and think about some anatomy, and some of this may be familiar and some of this may be not, but the muscles of the pelvic floor sit at the base of the bony pelvis. And together with the other structures, they support the organs of the pelvis. And this includes the bladder, the uterus in women, and the bowel. And they play a vital role in the continence mechanism, as well as needing to stretch considerably for childbirth in women. So when these muscles are not functioning optimally, the result manifests in symptoms of urinary incontinence, sometimes something called pelvic organ prolapse, and usually there's some sort of pain. Although these conditions are not life-threatening, they are severely debilitating and lead to significant reduction in quality of life. And as we hear, probably the issue of incontinence is still a stigma. It's not something that's readily discussed, and it should be. So I'm going to put up a little video now, and it's just to, and please, I apologize for the green at the beginning, but you saw that dreadful picture of the pelvic floor muscles, and it probably didn't mean very much. So I'd like to just play this now, and I'm going to talk you through how these muscles are in relationship to all the other organs, just so that we can contextualize what I'm talking about. Now, this video was, animation was put together by a former PhD student, and it is taken from MRI images from actually from my PhD. So it is real, it's not just an animation. So as I say, I apologize for the green, but it will stop shortly. So here you see the back passage, or the anal canal. And then you're going to notice the green is the external sphincter and the blue is the internal sphincter of the anal canal. This lovely yellow is the pelvic floor muscles, all the muscles that provide the support for the organs of the pelvis. This is a uterus. You can see how the uterus forms above, and it lies along the length of those pelvic floor muscles. You can see how the vagina is flat, and underneath in the blue is the bladder, and the urethra runs along the length of the vagina. And then we've got bigger pelvis muscles, the obturator internus, and it's all encased in this bony protective pelvis. And that's how it sits. And if we just flipped it so that you could see now, that was the diagram that I mentioned before. So hopefully that gives you a little bit more context of how these muscles are in our body and how they support those organs of the pelvis and what happens when they go wrong. So Ngaire had some lovely diagrams, and I'd like to look at some of these now as well. And this is a diagram that was put together by probably one of the gurus in our field, Professor Don Delancey from the States. And in 2008, he developed what we've called a lifespan model of pelvic floor disorders. So it's divided up into 3 stages. So from about when we're born to about 20, we have a inherent capacity of function for our pelvic floor, and it's determined largely by genetics, what types of collagen you have, what types of supporting structures you have, whether your mum suffered from prolapse, whether your mum suffered from incontinence may influence how your pelvic floor functions over time. But I'm not sure if you can see my pointer, but one of the inciting factors, particularly for women, and I will concentrate on women, though of course men also have pelvic floors and men also suffer from incontinence, but not nearly at the same prevalence or rate. The inciting factors, particularly for women, is childbirth, one of the most inciting factors. So you can see there's this big dip here in this graph. And if all things going well, the pelvic floor just goes back to as it was, and then you get this gradual decline over time until you cross the symptom threshold, hopefully around much later on in life. But sometimes the symptom threshold will be raised, and that happens if you don't recover after childbirth or if you have other intervening factors. Some of those intervening factors can be things like obesity, a chronic cough, and sometimes even things like high impact exercise for a long period of time. So that symptom threshold rises and you get symptoms of incontinence or prolapse earlier than you would normally. So what about the prevalence of incontinence? And I think I will concentrate for the rest of this on incontinence rather than confound things, but just remember that the pelvic floor muscles are involved in other support of those organs, so in other conditions such as pelvic organ prolapse, but that's probably for another day. The prevalence of urinary incontinence in women is huge. However, it ranges in the literature from anything from 25% to 69%. And that's probably because of the definitions that are used to define urinary incontinence and also how the instruments that we use to measure it. But nonetheless, throughout the literature, women are twice as likely to suffer from incontinence than men. For men, the biggest risk factors are prostatectomy, and probably obesity, but much later on in life. Whereas for women, we have many more risk factors. Interestingly, only in 2009, and that's quite some time ago now, the New Zealand Continence Association released a report on the financial costs of incontinence in New Zealand. And some of the statistics that came out were quite sobering. And this is now nearly 10 years ago when our population was smaller. And as Andy mentioned, we do have an aging population. So I suggest that these figures will only have got worse, not better. So 35% of community dwelling people over the age of 55 years suffer from incontinence. 50% in our residential care facilities suffer from incontinence. And sadly, it's often a reason for admission to any sort of residential care. And sadly, again, and listening to all the wonderful talks about what's going on at the James Henare Centre, we've only had one study that's looked at the incidence of incontinence amongst Maori and Pacific Island women, and that was in 1994. They did find, though, based on a survey, that the incidence of incontinence and pelvic organ prolapse was higher in this group than in the others. And then looking at the costs, they're enormous. So 142 million it costs annually just on treatment and personal protections. And if you look at the lost productivity to both employers and for the person themselves, this amount burgeons out to 2.1 billion. Now that was 10 years ago. It hasn't got better. So what are our potential solutions? So if you get a take-home message at all today out of my particular talk, it is incontinence is not a natural part of aging. So don't imagine that this is something that you all have to endure as we get older, because there is a simple solution that is not a cure-all for everybody, but there is unequivocal evidence that pelvic floor muscle training, or what you may know as Kegel's exercises, is an effective first-line treatment, in particular for the kinds of incontinence that occurs when you laugh, cough, jump, or sneeze, and that's called stress incontinence, and we know that is the most common type of incontinence. So in order to illustrate this, and just to show you that it is not a natural part of aging and that this pelvic floor muscle training is effective, I just want to talk about a really exciting trial that's just come out of Canada. So this was a large, what we call a non-inferiority randomized controlled trial, where they're looking at whether one treatment is better than another treatment. And this was all to do with the conservative management of urinary incontinence by pelvic floor muscle training. And they enrolled 362 community dwelling women over the age of 60 years, and they randomized them into either an individual, so that is one-on-one personal training with a physiotherapist, or in a group treatment. And they had a 12-week training program. And interestingly, they've had follow-up after the training, but also at 1 year. And you can see from these statistics that 70% still at 1 year post-treatment reported a reduction in symptoms, to the point now where it was no longer bothersome. 74% in the group also reported these same resolution of symptoms. That's less than a 10% difference if you look at the overlap of the confidence intervals, which the bottom line means that group training is not less effective than one-on-one in this population, which is incredibly exciting, because it means that this becomes a possible viable option, particularly when you're looking at the social aspect, as Ngaire was talking about before. You could do pelvic floor training in groups. So before I run away with myself, I just want to mention that I do consider the whole picture, and we know that older women in particular have other things that are going on in their lives. It's not necessarily that pelvic floor muscle training will cure everything. And often they present with a slightly different picture, in that urgencies that need to rush to the toilet may be more bothersome than the actual stress. They often suffer with more frequent episodes of urination, or they get up at night a lot to wee. Now, these conditions also will respond to conservative treatment, but they also may require a medication. And in aged care facilities, the incidence of urinary incontinence is high, as I said, often the reason for admission, but it's confounded by other comorbidities. So things like diabetes, a chronic cough, all those respiratory conditions only exacerbate the condition. And of course, your polypharmacy, where one of the side effects of often some of the medications is incontinence. So just to put it in perspective. So I'm going to finish off, I've still got a little bit of time, but I would like to talk a little bit more about our own research, and as Ngaire mentioned, about FemFit. So I lead the pelvic floor research group here at the Auckland Bioengineering Institute, and one of the huge advantages of that is I can leverage off the skill sets of all the bioengineers here. And some of those include instrumentation development. So probably 5 years ago, working with colleagues, because my background is clinical, I still have close connections with urogynecologists in particular and physiotherapists. And we identified a real clinical need in the domain of pelvic floor muscle exercises, but also in the domain of how do we measure pelvic floor muscle function more reliably. We know that 30% of women cannot contract their pelvic floor muscles effectively. So the standard advice, if you attend an antenatal class or if you have just had a baby, is to give you a bit of verbal instruction that usually starts with, well, can you squeeze, lift, and hold? Squeeze, lift, and hold what? It's a muscle we cannot see. It's a muscle we don't know whether it's working or not. And it's really difficult to know whether you're doing it effectively. And so sometimes what happens is you do it and you don't get resolution, so you give up. And we realize that the current solutions are not that effective. And what tends to happen is people manage the condition rather than treat it. So the containment industry, you will know, is huge. Walk down the aisle of any of your supermarkets, you'll see the diapers or the child nappies on one side, and sadly the adult nappies on the other side is just as big. And this is true for all population groups. So to finish off, I will introduce the FemFit, which we're really excited about. And this is our development of an instrument to help us with a clinical need that we identified 5 years ago. So this isn't such a great picture, but if you can see my pointer, this is the business end here. It consists of an array of pressure sensors. So we've got 8 little pressure sensors embedded into a soft silicon device The device itself is really thin. It's only 4 millimeters wide. It's flexible. It lies along the length of the vagina, and it transmits pressure from a little Bluetooth pod that just sits loosely in the underwear on the outside. And the beauty of this is it gives you real-time feedback via an app on a smart device, and it can tell you whether you've performed the contraction correctly or not. And so in the process of development, of course, we've done a lot of research studies, and I think Annie mentioned that this talk will be recorded, so I'm not going to go through these, but they will be there for your reference. So we have worked with people in Canada and people in Norway, as well as here, and looked a range of utilities of the FemFit for both incontinence, but also, as I mentioned, pelvic organ prolapse. So here I'm just going to start off. This is a little video. If I can play this video, watch the little sensors at the bottom. And this represents those pressure sensors that I mentioned in the device itself. So as you squeeze and lift, you need to activate the pink bars and not the blue bars. And then this will be transmitted to this little app on your phone, and the bird will guide you through a series of exercises that is so you squeeze, lift, and the bird will fly. Yeah, so we're excited about it, and we hope that there'll be a great uptake. And I'll just... So just to finish off, this is where we're at the moment. We've got a clinical trial in progress with 70 women with urinary incontinence. We have no upper age limit, so we're hoping to get some older women interested. In fact, I even had a letter the other day from an 84-year-old, a handwritten letter, which was delightful if she could participate. They'll be randomized into 2 groups. Some will receive the app and the device, and some just the app. There will be a 12-week training course, because we know it takes 12 weeks to change muscle. And the results should be in the early new year. And parallel to this, we are commercializing the FemFit. We've had great support from the Uni Services Auckland Inventors Fund, but also from MB and HRC to cover the research side of things, and we're now ready to launch into the next phase. So we've just received our TGA, which is the Therapeutic Goods Association accreditation, so we can sell our products in Australia. We've had a limited release of the FemFits for sale. We've had 64 units sold so far, and 5 clinical sites across New Zealand and Australia are referring this device at the moment, and we're heavily into the capital raising scene. So I'd just like to acknowledge all our funders. So HRC, the Robertson Foundation, which supported me, the Ministry of Business and Innovation, Uni Services, in particular the Auckland Inventors Fund, and the MedTech Corps. So thank you, and I'll hand back to Annie.
Thank you, Jenny. I see we have some questions starting to come in. Please do upvote your favourites. Our next speaker, Associate Professor Grant Searchfield, a prolific researcher, presenter and author, and co-creator of the Tinnitus Tunes website and one of the deputy directors of the Isdale Moore Centre. Grant will be describing some results from their work, identifying the role different hearing aids can have in reducing age-related cognitive decline.
Kia ora, thanks. Ko te tangata whenua, ko te mana whenua, tēnā koutou, tēnā koutou, tēnā koutou katoa. So what I'd like to do is to share my work that we are really partway through, exploring the relationship between aging and hearing, in particular the concept that if we address any hearing loss, we may go partway to addressing some of the contributing factors towards dementia. So as you know, and has been already raised, dementia in our aging community is quite a concern. It is one of the challenges that is really raising its head across the developed world as the population ages. And also, as you're probably aware, as we age, the likelihood that we are going to have a hearing loss also increases. And if we look at the population aged above 80, we can see that we're approaching around about 190% of that particular group will have some degree of hearing loss. Now, we may view these two things, the aging process and dementia and hearing loss, as being two separate things that develop together, but there's accumulating evidence that, in fact, hearing loss can be a contributor to the development and onset of cognitive decline and potentially dementia. So if we consider this, work recently undertaken by the Lancet Commission on Dementia, the original one was published in 2017 and recently has been updated this year. We have really a roadmap for the potential development of dementia across a lifetime, represented by these pathways over here. The grey represents risk of dementia that is really unknown. A contributor to this is going to be genetic and what we're really born with. But across this journey, there are a number of different factors that are potentially modifiable and contribute to the risk of dementia. For example, education, and we often hear about the role of physical inactivity in contributing to the potential risk for dementia. And of course, many of these different factors that can contribute to dementia, we can act upon and potentially reduce their effects, thereby reducing the potential occurrence of dementia. Now, perhaps surprisingly, the number one modifiable factor is in fact hearing loss. So individuals who develop hearing loss in middle life, who don't act upon that, are at increased risk to develop dementia across their lifetime. Now, this of course does not mean that all individuals with hearing loss will develop dementia, but it is a potential risk. Questions are then raised around why does this occur, and if you intervene, can this have some benefit in reducing the risk of dementia? So we have another diagram here that's really trying to show the potential relationship between hearing loss and cognitive decline or impaired cognition. Now, it is quite possible that there is a factor common both to dementia and hearing loss, and that factor is independently affecting hearing and cognition, so that they are both affected and therefore they occur together. But we also know that there are brain changes that occur with hearing loss that may be associated with cognitive decline, and we certainly know that a reduction in hearing can contribute to reduced social engagement, and this in turn can lead to impaired cognition. Now, one of the reasons why hearing loss in particular, potentially above some other senses, may be involved in this axis with cognition is the fact that hearing is continually activating our brain as our survival sense responsible for detecting and then our response to sounds in our environment. It is active all the time, even while we're sleeping. And that requires the brain to continually filter and modify what is coming through the auditory system. So it's a great form of exercise for the brain. If we have reduced input to the brain because of hearing loss, there is simply less activation of our cognitive processes. Therefore, the brain is getting less exercise. The question has been raised that if this is in fact contributing to poorer cognitive function, what would occur if we were to fit hearing aids? Would this in fact prevent cognitive decline or slow it? And there does appear to be evidence from a number of longitudinal studies now emerging that individuals who have hearing loss, who do not do anything about their hearing through midlife, are more likely to have poorer cognition than those individuals of a similar age who have good natural hearing, and those individuals who have a hearing loss who were fitted with hearing aids at a relatively early age tend to maintain that good cognitive health. Now, this evidence is emerging, so there's still a need to understand this to a much greater resolution and to find out details about this. With the support of the HRC, we began to undertake a study a number of years ago to investigate whether different hearing aid settings, one more tuned to what might be the cognitive demands of the aging population against a standard hearing aid fitting, might result in different outcomes based on both assessment of hearing and also assessment of cognition. So the question was, if we fit hearing aids, will we improve hearing? And will we actually improve the ability of an individual to undertake cognitive tasks? We divided that further because we were interested in understanding whether a particular hearing aid fitting would have more benefit than another. So this study is not complete, and so I'm actually not unblinded to tell you whether the different hearing aid settings had a different effect. But what I can report is the preliminary results looking at the division between the two clinics that were involved in this study. Auckland, this is the University of Auckland's hearing clinic, student training clinic, and our compatriots at Canterbury University in Christchurch. So we screened 244 over 65-year-olds, and those individuals falling below a particular cognitive score were eligible for the study, and a portion that fell above that line were ineligible. Now, what's interesting is that a relatively high proportion of individuals who signed up for the study, which required the fitting of hearing aids, who were eligible, actually declined to proceed further with the fitting of hearing aids. This is a slightly complicated story in what's happening with these individuals here, but it raises a little bit of concern for the outcomes that we found, in the sense of we have a group of individuals who potentially will benefit from hearing aids for one reason or another are not pursuing this particular avenue of management. And the story goes, and I'll show you some of the results here, that's slightly concerning, because if they were to pursue hearing aids, the results indicate that they would likely do better both from a hearing status, but also from a cognitive status as well. So we divided the individuals up. A number of the individuals were seen in Auckland and in Christchurch, and we're going through the various phases of that. We have a 6-month follow-up and a 12-month follow-up for those individuals. A number of people have yet to complete. Our recruitment was severely affected by COVID, because obviously we need to see individuals over 65 years of age. This is a vulnerable portion of our population. So even before COVID began and the lockdown began, we were beginning to reduce seeing those individuals. So what are we finding so far? Well, the good news is that for both the Auckland and Christchurch groups, hearing according to a questionnaire looking at quality of life, improved over both time periods for both clinics. Another measure of hearing handicap showed that the hearing aids were having a significant impact after 6 months of use, continuing on to 12 months of use. Now, the interesting point here is this next slide, and it shows cognition scores. And this is what we call fluid cognition. So these are the types of things that are generally affected as we age. So this is memory, short-term memory, ability to manage quick thinking tasks, essentially. And what we show here is that following a baseline score, this cognitive score improves over 6 months and then also 12 months. Another measure of cognition did not change. Now, this is a measure of what we call crystallized cognition. This is long-term knowledge. This is, if you like, the advantages of being the wiser, older person. Older memories, experience gained does not tend to change this aspect of cognition, and certainly hearing aids did not change this, which we weren't necessarily expecting to see in any case. So we have a situation in which those individuals who were fitted with hearing aids tended to improve cognition. We know that hearing loss and aging goes hand in hand. And so we have this sort of situation of thing one and thing two here. This is implications for hearing health delivery, but also considering the contribution of healthy hearing to aging healthily, and the ability potentially for early action on hearing to reduce some of the risk for cognitive decline. So if we want to, in fact, reduce some of the healthcare bill for cognition, then the early uptake of hearing aids may be one pathway to actually aid in that particular process. Much more work has to be done in this area, but the work done here in New Zealand is consistent with what we are seeing overseas, in that if individuals have a hearing loss and they're fitted with hearing aids, the likelihood that they will develop dementia is reduced to a degree. The extent of that is something for further research to ascertain, and over the remaining period of this year, early months of next year, we'll be completing the study, and we will begin to see whether the developments with regards to different hearing aid strategies actually have a greater benefit, which in turn will inform what we recommend to audiologists in the wider hearing healthcare sector. So thank you very much, and also thank you to HRC for funding this study.
Thank you, Grant. I love listening to your work, but our next speaker, Associate Professor Jennifer Craig, is an optometrist whose main interest is in ocular surface disease, including dry eye and tear film dysfunction. Jen's going to be telling us about dry eye and aging, and I think by the end of this talk we might end up a bit nervous about how much screen time we get these days, but let's see.
Thank you very much, Annie. Let me just share my screen. So, okay, so my role is to try and keep dry eyes out of the house. So as Annie says, I work at the university and I lead a team of researchers in the ocular surface laboratory looking at tear film dry eye ocular surface disease. These are my financial disclosures, but they're not specifically relevant to the talk that I'm giving today. So dry eye disease is it's very common. It's chronic, it's age-related, and it's degenerative. And in 2017, a massive body of work was published which described everything that we know about dry eye so far, and it also pointed out what the gaps were. And I was lucky enough to be involved with that as the vice chair. So what we, let me just try and move my thing forward. So the key structure that we're talking about in dry eye disease is the tear film. That's what ends up in imbalance and is the problem that we need to do something about. The tear film is tiny. It's about 4 microliters thick, 3 to 4 microliters thick, microns thick, and about 7 microliters in volume. And it has incredibly important functions. It's important for smoothing the ocular surface so that we can see clearly. It's important mechanically to protect the eyes with our eyelids moving to clear all debris away from the surface of the eye. Nutritionally, it's important because it allows the oxygen to diffuse into the cornea, because the cornea doesn't have any blood vessels, so it relies on the oxygen from the atmosphere. And it also contains important antimicrobials for the defense of the ocular surface. And it's built up into this really complex structure that matters. The order of it matters, and each of the individual components matters more than we could possibly have imagined, I think, 20 years ago. So there's the aqueous component, which is the bulk of the tears, and that comes from the lacrimal gland. There's the mucins, which are produced by the goblet cells of the conjunctiva, and they help the wettability of the surface of the eye. The surface of the eye is naturally hydrophobic, and so that wets the surface and allows the tear film to sit on the surface. And then finally, there's the lipid layer, which is the oils that come from the meibomian glands in the eyelids, and that forms a very thin superficial layer, but it's an incredibly important layer because it stops the rest of the tear film from evaporating too quickly. And each one of those components, as I said, is really important. They're all part of what we describe as a lacrimal functional unit. Each aspect is important. Each of the structures that the oils or the fluids come from is important. And also the neural reflex arc, which kind of holds the whole thing together, because that provides our stimulus to blinking and protecting the eye. And so all of this needs to be working properly, otherwise we end up with the tear film in imbalance and we end up with dry eye disease. And for the patients who are affected, and you may well know this, in an audience you would expect to have roughly 1 in 3 people affected. You may know about the symptoms. Patients complain of red rimmed eyes, heavy swollen lids, light sensitivity, watery eyes, discomfort is probably the main one, the burning grittiness, the feeling that you've got something in your eye when you don't, and blurred vision. And that blurred vision is a transient kind of blurring, where if you blink often enough, remember to close your eyes and open them again, then it clears, but it keeps becoming blurry. So it's impactful for patients. It has wider implications as well. In terms of quality of life, it's rated in an equivalent way to angina or having to undergo regular dialysis. People don't tend to think of dry eye as impactful as that. It impacts on productivity for people at work. Absenteeism is one thing, that's when you're not well enough to turn up. But the thing with dry eye is mostly you look fine, even if you have dry eye. Most people can't tell. And so most people will turn up at work, but often they don't get very much done once they get there. If they're in discomfort all the time, they're having to close their eyes, they're blinking all the time. And then they're not getting work done, and that's presenteeism, so being there but not getting things done. It's also got an association with depression and a massive impact such that patients end up suicidal in some cases. And there's an enormous financial burden, both for the patient who's buying treatments, but also just across the whole globe. The impact is enormous. So how does dry eye appear? Well, as I said, it could be any of those aspects, but you can break those down into 2 main components. It's either a reduction in tear quantity, and that's usually the aqueous we're talking about, the bulky layer in the middle, or it's a problem with tear quality, and that's usually either the surfacing of the eye, or most commonly it's the top surface, that lipid or oil on the surface. If we take the aqueous deficiency back to plumbing terms, then if you've got a sink and you've got the tap dripping constantly, that's what you want in a normal eye. Tears drain away through the plug hole. Tears evaporate, a small amount evaporates, but it's in balance so that there's enough tears on the surface. And in dry eye, that doesn't happen. There's not enough produced, but it still evaporates. It still wants to drain away, and so we don't have enough on the surface. In quality issues, in evaporative dry eye, the other part of the spectrum, then it's more likely, as I said, the lipid layer. So you have the oils, if they're not complete, if you don't have a good oil layer on the surface, then there's going to be tears evaporating too quickly. And we've got evidence to show that without a complete layer, or with an absent layer, if we can't see it clinically, then there's a 4-fold increase in the rate of tear evaporation, causing a dry eye. And you can get a combination of the two, evaporative and aqueous deficient. But for the aqueous deficient, for the evaporative dry eye, the most common reason to have that is meibomian gland dysfunction. And that's the oil glands. The meibomian glands are the oil glands in the eyelids. And they are the main reason that people have evaporative dry eye. The oil glands get blocked and the oil doesn't come out, and so you don't get the top surface on the tear film. It's very common, chronic and progressive. That little picture on the right shows you what the cross section of a meibomian gland looks like. The acini produce meibocytes. The meibocytes move their way up the duct and out onto the surface, and then they spread with the blink onto the top surface of the tear film, and that becomes blocked. The oils become a higher melting point, so they don't melt when they're supposed to at body temperature, and the glands obviously are inspissated. We looked at this is some data from New Zealand, and when we asked eye care professionals about how common they thought this condition was, and this is in patients walking through the door, not patients with dry eye. This is just in every patient walking in through the door. What proportion of them do you think have meibomian gland dysfunction, signs of meibomian gland dysfunction? And it's about 1 in 3, so very common. And if any of those aspects go wrong, then we unfortunately end up with a cascade of events, and that we term a vicious cycle or a vicious circle. And this is in its simplest form, this is the vicious circle. So we have tear film instability, where if there's not enough oil, for example, or the tears are too thin, there's not enough volume there, the tears become unstable. That allows the tears to evaporate too fast, and the tears become more concentrated. So we have a hyperosmolar solution. That does not go down well with the cells on the surface. They don't like that that environment, and they will produce inflammatory mediators, and the cells become damaged and they die. And without those cells on the surface, then these cells have the surface-bound mucins. Obviously, you don't have a good surface on which to build a tear film again, and so you induce more tear film instability, so that inflammation turns to damage, and you're back into the start of that cycle again, a self-perpetuating cycle of dry eye disease. So there are a number of risk factors that have been identified in dry eye disease, and age is number 1 as the first non-modifiable risk factor. What's also been identified, though, is the fact that we have a real lack of information about the natural history of dry eye, how dry eye develops, what's normal, what's not normal, what's age-related, what's disease process. And so that was the stimulus for us at the university to conduct a prospective registry-based cross-sectional study in order to evaluate the impact of aging on the ocular surface, and hopefully to empirically determine the optimal prognostic cutoff values, the ages at which the different markers for DED, which is dry eye disease, as well as its subcategories of aqueous deficient dry eye and meibomian gland dysfunction occur. Oh, sorry. So this is our study here. It's a single site study, and it was, we recruited from January 2018 to September 2019, requesting the presence of local community residents. Now, in order to try and reduce the impact of different environments that people may have been exposed to, because we know that in some countries with different humidities, different levels of pollution, that can vary things. So we tried to keep things as consistent as possible, with adults having to have lived in Auckland for the last 15 years, and any children who were recruited, born and raised in Auckland. And this was recruiting anybody, not just patients with dry eye symptoms. It was anybody who could involve. Some inclusions: no contact lens wear within 48 hours of being tested, no major disease or medications or ocular surgery recently. So our assessment procedure involved looking at a number of different ocular surface homeostatic markers. So these, the homeostatic markers we're talking about are those key ones that were in that vicious circle. So non-invasive tear breakup time measures the stability. It's like a bit like a staring test. How long can you keep your eyes open before your eyes are uncomfortable when you have to blink? The osmolarity, so the salt concentration, and then the staining, which indicates ocular surface damage. We also looked at symptoms with validated questionnaires. And from that information, we were able to look at the number of people who fulfilled the criteria according to TFOS Juice 2, that was that big workshop I talked about, fulfilled the criteria for a dry eye diagnosis, and also those that met up with the criteria for meibomian gland dysfunction and for aqueous deficient dry eye. We used a range of diagnostic tools, and these have improved a lot over years. So we try to use techniques that are as non-invasive or as minimally invasive as possible to learn as much as we can about the surface. So these are just some of the instruments we use, and we use clinical dyes in order to look at the surface to identify damage. These are some of the parameters that we measure. So we have up here, this is the non-invasive tear film stability measured in an automated way. The computer itself will detect when the breakup occurs, when somebody's staring at the, when it looks at the reflection as somebody watches a center point. We look at the oils on the surface. This is the meibomian gland oils. We can see the meibomian glands. If you avert the eyelid and look with infrared light, you can actually see the individual meibomian glands and look at the quality of those. We look at the surface of the eye and the redness. We look at any additional folds in the conjunctiva. We look at the lids and the lashes and telangiectasia on the lid margin. And we look at the damage to the surface. Corneal, which is the most common, and conjunctival, but we also look at the lid margin, which is a particularly sensitive area. And using those tests, we're able to decide whether somebody has dry eye, where they have symptoms plus signs, according to the criteria for TFOS Juice 2. So that's this part here. And then we conducted subclassification tests, and that's in order to break people down into the aqueous deficient or meibomian gland dysfunction groups, understanding that it's a spectrum and that patients may have elements, or participants may have elements of both. So we had 1,331 participants in the study. That's about 59% female, aged between 5 and 91 years, so a good spread. And we found that of our group, we had 31% had dry eye disease, 10% had aqueous deficient dry eye. So you can see with aqueous deficient dry eye, it's a lot less common than meibomian gland dysfunction, which came out at 25%. We did logistic regression analysis to look at the odds ratios of the various clinical markers per decade. So according to each decade, those are the results on the right, but I won't go through them in detail in this talk, except to say that there were positive associations between aging and the clinical markers of dry eye disease demonstrated across the board. And this is the most interesting table we get out, or the most interesting graphic we get out of this. And this is using Youdon optimal prognostic cutoffs to show that we actually, from the third decade, so this is in your 20s, we're starting to see changes already. Now you'll notice that people don't have symptoms until later. So we're actually identifying changes before people are symptomatic. And we're seeing changes to the meibomian glands, the quality of the oil, and then the spreading of that oil on the surface of the eye. And as you get older, you start to see changes initially in the epithelium, so damage to the epithelium just at the lid wiper area, that's the sensitive area. We see changes in stability of the tear film and in the tear film osmolarity. And that's where the symptoms start to appear. Then in the 5th decade, we start to see changes in the aqueous component. So much later on than the other changes, these are occurring in the 40s, and we start now to see conjunctival staining, and then finally we see corneal staining in the 6th decade. And that's quite relevant because most eye care professionals looking for dry eye disease look for corneal staining, and so you can see why there are many patients out there perhaps not receiving the care as early as they could. And the pattern's similar for meibomian gland dysfunction and for aqueous tear deficiency. They're similar, only you can see that the aqueous tear deficiency it starts to appear later on. It kicks in just that little bit later. So why does it occur? Well, it's the lifetime exposure to a multitude of environmental and physiological factors, and these lead to changes that occur in the body, the changes in hormonal regulations, in the regulation neurosensory pathways. We see ocular surface inflammation developing and an imbalance in the tear film, a loss of homeostasis. And that has big implications when we think of our aging population. You're familiar with the graphs along the bottom where we see it's becoming more, but we see a 24% increased odds of developing dry eye disease per decade. So that's going to create massive global burden, obviously, with our aging population, which is estimated, and this is New Zealand statistics, it's estimated our over 65s will increase by 77%. Yeah.
I'm sorry, we're running out of time.
Okay, I'm just about to wrap up, sorry. Yeah, so 77% for adults, for the older group, compared to only a 7% increase for children. And the earliest changes are in MGD, which happened in the 20s rather than in the 40s for aqueous deficiency. And so what we've identified is a window of opportunity. So before the symptoms come in, it appears there is functional reserve when you're young, so that you don't notice the changes that are occurring in the 3rd decade. But probably we should be getting in at this point and doing something about it to try to stop the dry eye developing at that point. So that's the breaking that vicious cycle we talked about before, and specifically that MGD part, which feeds into the instability by trying to treat the pathophysiological mechanisms. And that can be done with a range of different treatments that are outside the scope of this talk, obviously, but we have a number of different ways that we can be doing that to try and help patients. So in conclusion, age is a significant risk factor for dry eye disease, but we want people to age well, live well into older life. Lifestyle is a massive, the things that we're doing to ourselves. So I didn't go into that in detail, but there's the computer screens, the screen time that we're doing. But the aging population has increasing demands and expectations, rightly so, as somebody who's getting older myself. We want to be able to do a lot into older age. And so I think there's a great unmet need for preventative strategies to help maintain ocular surface health during life. I'm pleased to say TFOS has agreed with the lifestyle lifestyle issue, and it's something that's going to be the focus of their next workshop that's coming up, and I'm honoured to be leading that as the chair. So a lot more work that's going to be done in this field. Thank you very much for your attention.
Great, thanks, Jen. Our final speaker is Professor Vanessa Burholt. In a previous life in the UK, Vanessa led an innovative co-creation centre for research in ageing and dementia, and today she's going to tell us a bit more about what a venture like that might look like in a New Zealand context and what we could do in that space.
Thank you very much, Annie. Okay, that's great. Yes, as Annie mentioned, I have been in New Zealand for around a year now, and previously I was director of the Centre for Innovative Ageing at Swansea University, and simultaneously the director of the Pam Wales Centre for Ageing and Dementia Research and the founding director of the Institute of Creative Ageing Industries. And central to each of those was co-creation and co-production of ageing research with older people and stakeholders. Over the last year with Ngaire Kerse, who presented about Awesome earlier this afternoon, my mission has been to start the process of developing a centre in the University of Auckland that would deliver creative and innovative solutions to improve health, well-being and human flourishing, unlocking human potential by giving older people researchers and other stakeholders the opportunity to co-create world-class interdisciplinary ageing research. So the University of Auckland is well positioned to bring together world-leading research expertise in social and clinical gerontology, participatory methods, kaupapa Māori and Pacific research, epidemiology, engineering, digital technologies, architecture and design to address global ageing through co-created research with older people. And we've heard a lot about some of the research that's been going on in the university today. Global ageing, the unprecedented increase in global populations over the age of 60 is a long-term trend and an international issue that's ripe for research to channel opportunities and mitigate possible consequences. So establishing a Centre for Co-Created Ageing Research would comprise a complex consortium of research centres in the University of Auckland, alongside private sector, public sector, third sector stakeholders and older people, which will address this long-term trend. Between 1950 and 2050, the global population is projected to increase 3.7 times. However, the number of people 60 plus years will be increased by a factor of 10, and the number of people aged 80 plus years will increase by a factor of 26. Consequently, the total population will increase by 2 billion, but the older population will increase by 1.3 billion. So we can look at this in terms of global ageing opportunities. Currently, the silver economy is estimated to be worth around $23 trillion. Spending by older people in New Zealand is expected to rise to $65 billion in 2051 and $85 billion in 2061. So a Centre for Co-Created Ageing Research could activate industrial potential in New Zealand by unlocking one of the fastest growing yet most misunderstood market segments. We could apply smart specialisation and consumer-centred thinking to understand the challenges and opportunities of longevity and to catalyse research and innovation across the university. The rationale then for co-creation builds on the strength of academics, stakeholders, but also that repository of knowledge and insight that is within the older population itself. Co-production requires an in-depth understanding of the various conditions which are conducive for generating co-produced activities. An understanding of co-production with older people is one of University of Auckland's research strengths. So we have the skills to work with Māori Kaumātua, which we've heard from Marama Muru-Lanning earlier in the day, people from other cultures and other ethnicities, and older people living with both functional and physical impairment. Arts-based research methods are part of our arsenal of research tools, which can also incorporate Matarangi Māori methods. As populations age, the number of people experiencing chronic conditions more frequently associated with later life also increase. And this is also often presented as a challenge to health and welfare systems, and also for unpaid care from whānau, family and non-kin caregivers. But research can contribute to healthy ageing. For example, preventing or delaying I'm sorry, my screen's gone strange. I can't actually see what my screen says now. But preventing measures or managing illness or delaying biological processes. There are also opportunities to improve the quality of life for those that live with functional or cognitive impairment. So we can undertake research to support caregivers, improve the fit of the environment to match the older people's needs, or develop products that either compensate for deficits or enhance the quality of life. Enabling healthy ageing in turn can facilitate social connections and impact on well-being for older people. Also, as global workforces age, more employees may be able to work productively if research is used to develop age-friendly workplaces and policies. So it's anticipated that a Centre for Co-Created Ageing Research would operate around some core themes that would allow both the flexibility and innovation, but simultaneously reflect the World Health Organization's definition of healthy aging, which is about creating the environments and opportunities that enable people to be and do what they value throughout their lives. So under each of these research themes, under research on health and wellbeing, we would target the transformation of health and social systems from a disease-only focus towards a provision of integrated and relationship-centred care. This would underpin continued and equitable access to disease prevention, promotion, treatment, and rehabilitation. Promoting wellbeing, research would also look at quality of life issues and psychosocial outcomes for older people, also incorporating the needs of whānau, family, and caregivers to older people. Research under the theme of place would contribute to human settlements that are inclusive, safe, and resilient, improving the fit between older people's needs and the environments in which they live. Research would recognise that wide range of capacities and resources among older people, respecting their decisions and choices, protecting those who are most vulnerable, and promoting older people's inclusion and contribution to all areas of community life. Under our work and retirement theme, research could prevent older people from falling into poverty by contributing to the development of flexible retirement and pension policies and promoting lifelong learning. Responding to an ageing workforce, research could underpin the development of age-friendly and age-diverse workforces, changing employers' attitudes about the value and contributions of older workers. And our cross-cutting themes take into account the digital economy, architecture and design, equity, inclusion and sustainability, with the latter considering future generations. The centre would establish and maintain a community of co-creators, and that would comprise kaumātua, older people, caregivers, whānau families, practitioners and professionals in the public sector, business and industry, with an intellectual hub comprising a complex of research centres. For example, the School of Nursing, Population Health and Medicine in the Faculty of Health and Medical Sciences, the Augmented Human Lab, the Future Cities Lab, Design School, the James Hanari Māori Research Centre, and the Centre for Automation and Robotic Engineering Science, to name just a few. We would also foster cooperation between our stakeholders, building partnerships, and developing and prioritising new ideas for translation into research through these core partnerships. We'd also anticipate establishing appropriate facilities. So in the long term, we would like to establish a living lab, which is a daily living facility that could be used by our collaborators to create innovative environments, products, experiences and services. And just to give you an idea about what a daily living facility could look like, this is an example from the Bosch Smart Life Lab. So a daily living facility could comprise office and a workspace, kitchen, bedroom, living room and bathroom. And they're built as versatile platforms for authentically staged living and working, cooking and eating, and coming and going. So you can see from this picture that the working fixtures and home-like furnishings can be selected to make rooms feel quite similar to a domestic environment. And each of the components in the daily living facility are mobile. The surfaces mean you can attach products to them, and they're hollow so that you can cable and add different types of high technology in a fairly unobtrusive way. The lab could also be equipped with sensors and monitors, for example, kinetic and kinematic analysis, EEGs, real-time eye tracking, etc. So in addition to establishing new and appropriate facilities for co-produced research, the Centre for Co-Created Ageing Research would also provide the infrastructure to initiate and generate innovative co-created ageing research and support the existing centres to co-create ageing research as well. We want to build research capacity, to develop a critical mass of researchers with expertise and competencies in co-created ageing research, and to coordinate the ageing research activities across the university to disseminate to a range of audience to ensure impact. So fundamental to our mission is a common cause and agenda for co-created ageing research that can incorporate a kaupapa Māori inquiry paradigm. The Centre's approach to research would be based on 4 elements: collaboration and equitable involvement in research, solidarity and capacity building, empowerment and action for change, and sustainability. Now, co-produced emancipatory gerontological research, when done well, can impact on social justice, reduce inequities, further human rights, and positively impact on quality of life and flourishing of those involved. It can also enable individual, collective, and structural processes of empowerment, which in turn facilitate desired improvements in the well-being of older people. Our final principles, of course, of co-production will, of course, be co-developed. Oh, don't know why that ran through. Okay. For some reason, it doesn't want to stay on this page, so I'll tell you quickly. We anticipate that the cluster of research excellence could deliver significant economic and social benefits. And in summary, to impact on health, well-being and flourishing of older people, we'll create new knowledge through our innovative, robust research, align our research to respond to priority areas and global challenges, and translate our knowledge to reduce inequities and improve opportunity to live a long and healthy life. We'll involve and engage older people to ensure that our research addresses diverse needs, acknowledging, valuing, and responding to difference with regard to age, socioeconomic class, health literacy, race, culture, ethnicity, gender, physical and mental abilities, sexual orientation, and religion or spiritual practice. We'll involve and engage NGOs as co-creators and business as co-creators and users of research to contribute to the overall health, well-being and wealth of New Zealand. And we'll involve and engage policymakers, clinicians, health and care practitioners to improve services for older people. For external partners and potential partners with a Centre for Co-Created Ageing Research, the sorts of resources that might arise from co-produced research would include data on the scale of the issues affecting older people, so that DHBs, service providers, NGOs and other organisations are able to plan to address these accordingly. Core outcome sets that define how quality should be measured in care, in interventions and in trials, from the perspective of older people, their whānau and caregivers, as well as the perspective of professionals. Practical resources, which are solutions and resources for older people living in the community, their whānau, family and caregivers. Policy forum, policy briefings on recommendations arising for the research. Public seminars increasing knowledge of healthy ageing issues and health literacy. And training opportunities for both health practitioners, but also for lay researchers. Clinical practice guidelines and HR guidance, which would disseminate good practice for managing and supporting old workers to remain in work longer if they wish, but also contributing to age-friendly and age-diverse workplaces, which would unlock a vital talent pipeline. Commercialisation of products and services, and the development of age-friendly commercial leisure, culture and other spaces. Importantly, in understanding the older consumers' demand for products, services and experiences for active and healthy ageing. And finally, producing new knowledge and understanding that challenges the medical and deficit model of ageing and raises awareness of the contributions to society made by older people. So we're currently in the process of consulting and developing the ideas around a Centre for Co-Created Ageing Research. And as co-production is as central to everything we do, I'd like to leave you with some questions, the answers of which will help shape our future activities. That is, if this screen, no, doesn't want to show you any questions. Right, there we go, it's saying there. If you'd like to contribute and feedback on whether our research themes cover the areas you'd expect us to address, whether there are other outputs you think we should produce, or how we should communicate and stay in touch with organisations and older people that wish to be involved in that, then please use my email address at the bottom to contact me. Thank you.
Thanks, Ness. That's some exciting times ahead. I'd like to thank all our speakers. I see some questions have been answered. We have run out of time, so we'll send all of those answers out with the recordings. I'd also like to invite you to contact us. My contact details will be in the email. We'll include the speakers' contact details. If you have any questions about ageing research in the university, whether related to these presentations or not, please don't hesitate to reach out. We're always looking for new partners and collaborators, and we love to be able to connect within our little New Zealand research ecosystem. So yeah, with that, I'd like to say thank you very much and goodbye.